Okay, good afternoon. It's nice to see you. Today we'll be talking about children who have higher incidence disabilities. These are primarily the children that you are most likely to encounter in a general ed classroom. They are children, when we look back at the bell curve or the normal distribution of scores, these are the youngsters who have difficulty in the mainstream classes but who are low achievers and have qualified as having a disability label. But they are youngsters who will be operating much closer to the mean than the children with low incidence disabilities that we talked about last time. Now, this should make sense to you in terms of the fact that if you look at the normalized distribution of scores, what you find with these children is our bell curve is here, and so if they're closer to the mean, there are children who are likely to be falling between here and here. Children with low incidence disabilities are likely to be on this end of the spectrum. Now, we know that there are more children in this area because it's closer to the mean. And just like the fact that there are more ladies who are 5'3" than ladies who are 4'12", 4'11", there will be more youngsters in disability categories who are operating closer to the mean. So that begs the question, really, and our focus topic for today is, how do we know when a child is individually different or that he has a disability? How do we know when individual difference actually represents something rather than a deviation that would be expected in terms of the way a particular characteristic distributes on a normal curve? Let me give you an example that I think will make sense to you. We have a few guys in here. We'll pick on them since they're outnumbered, right? So say we had a guy in here who was 6'5". What do you expect you could say about the length of his legs? He's likely to have longer legs than a fella who is 5'6", isn't he? Okay, then let's think about basketball for a little bit. What if we asked these two guys to play basketball? What do you think would happen? We don't really know, do we? Because everybody who's tall isn't a good basketball player, and everybody who's short is not necessarily a bad basketball player, right? But if we looked at the Houston Rockets, what do you think we would find about their leg lengths? Guys who play for the Rockets are pretty likely to have long legs. Most of you probably don't remember Calvin Murphy, but he was a basketball player who happened to be 5'8" and received widespread recognition and made more free throws than anybody in the whole world and was very famous. And he was only 5'8". But he would certainly be, well, he looked like a little ant running around out there with all those Rockets who were 6'5" and 6'10" and very, very tall. So my question to you is a man who's 5'6" disabled? Probably not. Hopefully not, right? If, however, he were put in an arena where basketball playing was the measure of man, he might be somewhat disadvantaged. Would you agree? He might be not be too good at playing basketball, but we wouldn't call him disabled. Yet we know that there are situations where leg length can reflect what we know we can make a differential diagnosis about, that is a disability. For example, individuals who have dwarfism also have very short legs, and the length of their legs, along with other physical characteristics that they exhibit, allow us to say that they have a disability. They are members of a category of individuals who can be differentially diagnosed based on a set of characteristics, one of which results in their having shorter legs, right? So the question is, with learning, where on this continuum or this normalized distribution of scores do we say, aha, you're just not very good at school. It's not your best thing. Like a short fellow's best thing might not be basketball. When do we say you're just not very good at school? And then on the other hand, when do we say you have a learning disability? Does that make sense to you? It's a puzzle, isn't it? And one of the things that you will find about the students that we'll talk about today is that it is very difficult for us to determine whether the nature of their problem is really reflective of a disability or an individual difference that makes them just not particularly good at the kinds of skills and activities that we place so much importance on in the general ed classroom. Does that make sense? I really dislike the term learning disability very much because I think it calls to mind some sort of symptom complex that says a child who has this does this and this and this and this and can be taught in this way and this way and this way and that way. And the truth is, we don't have evidence to indicate that with children who are learning disabled. If we know that a child has a learning disability and he doesn't read very well, we would go about teaching him in very much the same way we would go about teaching any child who didn't know how to read. We would start with the letters of the alphabet and the sounds that they make and the symbols that are associated with those sounds. And we would put those things together in configurations that are represented in the words that the child needs to learn. So I want you to think about that because we throw around some of the terms and labels that we'll be talking about today as if they had a profound consequence and significance to the people who hear those letters. And we really don't know very much more about a child if we say that he has a learning disability. We really don't know much more about him than if I told you he's not very good at school. We know that he doesn't compete favorably with his same age peers on measures of school achievement. So I want you to think about that. When we talk about higher incidence disabilities, they are the ones that are the most likely to be seen in your regular ed classroom. They include the categories of speech and language impairments, learning disabilities, emotional disturbance, and mental retardation, mild to moderate mental retardation. Now, if you lumped all of these children together, what you would have is 90% of all children who are labeled with a disability. Now, this once again should make sense to you in terms of what we were talking about a minute ago about the normalized distribution of scores, because that's the area under the bell curve, this area that's closest to the norm, where most individuals who are members of our species are likely to fall. So we will talk about those individually, beginning with speech and language. Speech, which is really two different things. Speech is the system of forming and producing sounds that really form the basis of our language, and there are several disorders of speech. They include such things as voice disorders, articulation disorders, fluency disorders, and the like. Language, on the other hand, is our system for communicating ideas or communicating thoughts to one another. And language disorders are likely to result in a failure to appropriately use or understand language. This can be either expressive or receptive. We'll talk a little bit about that later when we talk about aphasia. But certainly, if a youngster in your class is identified as having a speech or language disorder, he or she will likely be sent to a speech-language pathologist who will assist you in remediating that child's disabilities. To be more specific about these, our speech disorders are things in the nature of voice disorders, like the way a person expresses sounds and as he or she goes about the business of producing words. And so you may have known people in your life who had problems with volume. Have you known people who speak too loud or speak too softly? Drives you nuts, doesn't it? As a teacher, you're likely to have a child in the classroom who doesn't properly modulate the volume of his voice. And when it happens, it drives you nuts. You know, you're in there with them all day, every day. So while this is rare, sometimes it happens. You may have a child who, for one reason or another, doesn't speak loudly enough to make himself heard. So that's another type problem. Pitch or nasality can be a problem. Have any of you heard people, you may have known them as adults, who what we refer to as talk through their nose, you know, who direct their speech through their nose? So certainly nasality can be a problem, and children can be taught to redirect their speech and breath so that they speak in normal volume. Some children have hoarseness for one reason or another. Usually it's a physiological problem that may or may not be able to be treated. Articulation disorders are difficulties that children have in producing words. They may leave sounds out, or they may distort sounds. We have the child who, a child with a hearing disability, for example, is very likely not to hear some sounds in our normal phoneme, our range of phonemes. That child may not hear one or more sounds, and so when he reproduces words, he doesn't say the sounds that he doesn't hear because he hasn't had a model for those sounds. Articulation disorders, many are also developmental. You have children who don't talk plain. So you may have a child who says fruck, for example, instead of truck. So these are articulation disorders, and kids need additional practice in identifying and reproducing the phonemes that they're saying incorrectly. Fluency disorders. Usually the most common fluency disorder that we have is really stuttering. Children who are likely to have a fluency disorder that causes you concern are more likely to have stuttering. Language disorders, on the other hand, have several categories that they may fall into. Phonology is the first one. They may have difficulty blending and segmenting sounds that the individual letters or groups of letters are made up of. Morphology is in the meaning and structure of words. They know the word, but they don't necessarily know how to use the word or structure the sentence in an appropriate way, grammatically. Pragmatics are the use of a language in a social context. I can't think of a good example of a pragmatic issue. Well, I'll give you an example of a pragmatic use of language. You might say, if you were a first grade teacher, everyone close your mouth. Now, if you were thinking about a literal interpretation of the word close your mouth, that would be impossible, right? I mean, you know, we don't really close our mouths. But when we say close your mouth, what do we mean? Be quiet or stop talking. So I'll tell you why that came to my mind. When I first started teaching school, I used to teach school in Honduras. Can you believe that? I lived in Honduras. And so all of my little children spoke Spanish. But, of course, I didn't. So there was the problem. So, but I did know how to say close the door in Spanish, right? Cierra la puerta. Isn't that wonderful? Doesn't exactly make me bilingual. So I'd tell the little children, cierra la boca. And guess what? They thought I was crazy, right? Because the pragmatics of Spanish doesn't allow you to say, close your mouth. It doesn't mean anything, does it? Well, it certainly didn't mean anything to these little children. And probably if it means something to you, it's because you've extrapolated that from your use of English. You would know only because you know how to speak English. So that's an example of the pragmatics of language. Now, aphasia is one of the most severe language disorders. It's not terribly likely that you would have a child with aphasia in your classroom. I suppose that it could happen. But aphasia is a severe interruption in the way a person either speaks or comprehends language. And they're very, very different. Expressive aphasia and receptive aphasia are two very, very different things. With expressive aphasia, a child may know exactly what you're saying and exactly what it means, but not be able to get it out because they are physiologically incapable of making sounds. Sometimes we have children with severe cerebral palsy, for example, who understand language perfectly, but because of their motor involvement, they have a lot of difficulty in reproducing those sounds. So we refer to those youngsters as having expressive aphasia, because the problem they have is not a language disorder. It's not understanding the language. It's the speech. They can't produce the speech. Children who have receptive aphasia, on the other hand, have the reverse problem. They may be able to reproduce sounds and words and phonemes perfectly, but when they do so, it doesn't mean anything to them. So it would be very much as you're mimicking words in Greek. You might be able to reproduce words perfectly in Greek, but they wouldn't mean anything to you. You wouldn't have any idea if you were saying, I want a drink of water, or where is the bathroom? That's what happens to children who have receptive aphasia. They hear the words, their hearing is perfect, but for some reason, they have a disorder in the cognitive processing of language. So even though their hearing is perfectly intact, they may be able to hear a pin drop in the next county. But when they receive this information, it doesn't mean anything to them. So they never, and when they're little babies and start learning to talk, they reproduce sounds. I want a drink, mama, daddy, all of the things that normally youngsters begin to say, they start saying as well. But they don't ever make the association between using language and having their needs met. So they may say, I want a drink of water, when what they mean is, I want to go to the bathroom. And of course, when this happens, language is useless to them, and so ultimately they quit speaking, not because they're unable to hear and reproduce sounds, but because the words don't mean anything to them of significance, and so they're of no use in meeting their needs, which is really what we use language for, you know. Probably if we didn't all talk, we'd never get our needs met. And if our needs weren't met by talking, we'd go back to an age when there was no language. In any event, these are some of the characteristics that are exhibited by students with speech and language disorders. We don't know all of the causes or even the characteristics of youngsters with speech and language impairments, but certainly we know that some youngsters have severe language delays during early childhood, and We don't know why. Voice disorders can be caused from a variety of reasons. A child could have a growth on the larynx or something, infections, trauma to the larynx. There may be some physiological involvement that is the result of an accident or illness a child has had. We may be, nasality is often caused by having a child having bad tonsils and adenoids that redirect, the pitch of their voice. These kinds of things. You might encounter a child with a cleft palate or a cleft lip in your classroom. These disorders are birth defects, actually. They're the failure of the musculature in the roof of the mouth and the lips to close. Interestingly enough, who has dimples? Does anybody have dimples? Well, dimples are the same kind of birth defect as a cleft palate or a cleft lip. They're just things that we put a different interpretation on dimples because we think they're darling and reinforce children who have dimples. Look at you, grinning over there from ear to ear. You do have dimples, don't you? But it's a failure of these muscles, these cheek muscles, to close, and so when you smile, that the hole that's left in there sinks in. Well, the same thing happens when a child has a cleft palate or a cleft lip, only we consider it a different type of disfigurement, and these youngsters often have, particularly if they have a cleft lip, have lots and lots of difficulties learning to make sounds. Now, in the years I've been in special education, medicine has come light years in enhancing the physical appearance. The plastic surgery repairs are so effective now. When youngsters, often when you meet people, encounter people all the time that have a cleft palate or a cleft lip, and you don't even know it because the repair is so phenomenal. Or you may just see a hairline scar right here on somebody and know that they've had a cleft lip repair, but the surgeon is so skillful that you hardly see that anymore. And it's a wonderful advancement because these kids used to have lots and lots of difficulty learning to speak appropriately, and also with feeding because of the cleft palate. When they will swallow, there isn't a roof of the mouth to push food down against, and so particularly when these youngsters were infants, they had lots and lots, their parents had lots and lots of difficulty feeding them. So there you have it. Stuttering, it's important for you to know that there is no known cause of stuttering. The most current line of thinking is that stuttering is the result of some very slight brain dysfunction that we can't identify yet. There are lots of places in the United States, particularly one in Tennessee I think is very noteworthy, that have come a long, long way in treating stuttering. It's always been a puzzling disability because there are examples like when stutterers sing, oftentimes they don't have a difficulty with stuttering, or when they perform in choral reading with a group. And so this led to a line of research that says, gosh, when they don't hear themselves, they seem to do fine. And so what if we blocked the sound of their speaking back to themselves? Would that result in fluency? And I don't know all of the sophisticated ways they've gone about doing this, but there are places in the United States where they've come light years in advancing these techniques that allow stutterers to wear a small communication device that blocks the feedback of their own voices, and they're able to talk and train themselves to redirect and stop at reasonable intervals so that they become very, very effective communicators. And it's a wonderful intervention. Youngsters who stutter have a great deal of difficulty with issues like their self-esteem and the feeling of being unable. As adults, whether it's good, bad, or indifferent, it's probably horrible. But it seems to be a human characteristic that when we meet one another, our initial judgment is based on what? What's the first thing you think when you see somebody? Your first point of evaluation of another individual is based on what? Their personal appearance. And what is your next evaluation based on? How they communicate with you, what their speech is like, and how they communicate with you. Oftentimes, youngsters who stutter, even for well-intentioned people, you're uncomfortable in listening, and so maybe you don't respond as positively and openly, not because you don't want to, but because you're uncomfortable in knowing how to increase their comfort levels, right? So the advances in treating stuttering are very important. Speech and language disorders often accompany other disabilities. One of the things that we know is that if a youngster is deaf, it's almost inevitable that they will have difficulties with speech and language. Why would that be?
They can't hear the language.
I'm going to reinforce this lady that punched down on her microphone.
Because you can't hear when you're an infant to mimic the sound your parents are making.
The way we transmit speech and language to each other is through modeling, right? The parent and other significant individuals in a child's life provide role models. And so we mimic those role models, which is why we end up talking like the people who taught us to speak. I'll never forgive my mother and father for that accent they had, right? In any event, if we can't hear those models, we have nothing to mimic. And discovering how to speak by trial and error would be impossible, right? One of the most significant, we'll talk more about this when we get into speech and language, but certainly there's a whole theory of social psychology by a guy named Bandura that's based on vicarious learning, or learning by observational learning. Modeling is what it's called. The vernacular for that psychology is modeling. How many of you have had Dr. Lieberman already? Remember talking about Bandura and social learning in there? Well, Bandura has become rich and famous because he discovered that no matter what, our society is too complex for people to learn everything by trial and effect, right? By trial and error. So what we do is we watch you do it and say, aha, I can do that too. And of course and language is a primary example of that. We would never be able to acquire language if we didn't have models. So when a deaf person cannot make use of the models because they don't hear, then they can't never learn to reproduce the words and use language in order to have their needs met. We'll talk more about that next week when we get into low incidence disabilities. Certainly parents and teachers are those who initially identify problems in this area. And as the primary teacher, you EC4 people are very likely to be the first to notice that a child has a speech and language disorder and refer that child for possible delays. I'll give an example about a child I know that I worked with at one time, whose mother was a special education teacher and father was a physician of all things. And they had a number of children, but this involved their second child. I actually think this woman had 6 little boys, so she'd have an excuse probably for never getting out of bed, in my view. Just kidding, but think about it. If you had 6 kids, that would be tough, wouldn't it? Anyway, the second child was a darling little boy, and he was thought to be very shy, and the older brother was very precocious. From the word go, from the word jump go, he was very, very precocious, did everything real quick. And so the older child formulated the habit of speaking for the younger child, right? Nathan wants a glass of water, Nathan wants this, So time went on and the child went to kindergarten. And the kindergarten teacher called the mother one day and said, "I don't think your son is hearing." And the mother said, "Really?" She said, "No, I noticed that I give directives and he doesn't follow along. Have you ever had his hearing checked?" And the mother said, "No, we never thought anything about it." Because they had fallen into this familial pattern. And when they asked a child this question, he would be coy and shy and not answer. And of course, the brother would step right up and take care of everything for him. Well, they had his hearing checked and found that he was one of those children who had serious ear infections and had fluid on his ears and had not been hearing about 90% of everything that was said. And as a result of it, it wasn't that he was shy and didn't want to speak. The truth is he didn't know how to speak, and he had devised a face-saving coping strategy which worked for him at home, and that was having his brother do it all. So, needless to say, they took the appropriate medical action and restored his hearing. And this seems impossible, but have any of you had a child with an earache, or can you remember being a child with an earache? We're plagued with them. Here, I grew up on the desert. We didn't have earaches, thank goodness, but people down here have earaches and allergies and roaches and all kinds of things. Head lice, all kinds of things we don't have to worry about in the country, I'm happy to say, but I'm not anxious to go back there, so I guess I'll deal with the roaches. But in any event, if you have had an earache, an ear infection, you can probably say that most people say it's excruciatingly painful. And most children who have earaches scream their heads off. And it would be hard for me to believe that this kid just sat there with an earache for 5 years. But the truth is, I also had a child who was plagued with ear infections and never cried about it a single time. Would cough his head off, his nose would run, take him to the doctor, ear infection, ampicillin. He thought it was a strawberry milkshake by the time he went to school. The child's had enough ampicillin to float the battleship Texas. But in any event, he never cried over this, and so apparently this child was the same way. I'm telling you this story only because I think as a classroom teacher, particularly those of you who are interested in the early childhood grades, may have a pivotal role in helping to identify children for whom this may be an issue. And of course, in the case of this young boy that I was speaking of, he had suffered some severe lags in language development and also probably some cognitive aspects that go along with that because his hearing had been blocked for so long and no one had provided him with either a language model or an alternative means of communicating his needs that was effective, what was an effective coping strategy. So we know that you may be often in a position to do something about this. In order to prevent others in your classroom from teasing or bullying children who have speech and language disorders, it's very important for you to communicate with your class and let them know what the nature of the disability is, and also, in my estimation, establish a zero tolerance policy for children ever making fun of any child based on how they talk or any other demographic characteristic. I mean, there's just no excuse for it, and it constitutes psychological abuse. A parent's primary role, first and foremost role, is ensuring the physical and psychological protection of their children. And as you are the parent surrogate for the 8 hours that that child is in school, your primary role before any other is to ensure the psychological and physical protection of the children with whom you've been awarded the responsibility. And so, I just don't have too much problem with that. And I want to tell you, the middle school teachers paid the heat for it. Who are the middle school teachers? We don't have any in here, do we? Well, God bless you, my dear. We're going to let you off the hook on this because it's the EC4 teachers who do the groundwork for teasing and bullying to occur in the middle school. By the time they get to you, it's too late. Kindergarten, how many kindergarten teachers do we have in here? It's your fault. You're the ones. You're the ones where the teasing starts. And you need to sit down and talk with children and explain to them why we don't make those kinds of remarks. Everybody's had ugly things. Everybody knows what it feels like to get your feelings hurt. That's a universal experience that anyone can tap into. And you can sit down. Don't drive bamboo shoots up their fingernails. Sit down and talk to them and say to them, what did you say to him? How do you think that made him feel? How would you like it if someone said that to you? You think a 5-year-old can't follow that? Of course they can. What is some other way you could say that? I want you to sit down and think about that for a while. And think of some other ways. Well, he made me mad. He took my so-and-so. Well, it's okay for you to be mad. It's okay for you to be mad. But it's not okay for you to say ugly things. So sit down for a few minutes and see if you could think of another way to tell him that you didn't like what he did. Because calling him names doesn't really communicate anything except you have bad manners. I'll get back to you in a minute. And then go back to him a little bit and say, have you thought about it? We sure did miss you in our group, and we want you to be here. But you can't be with us, you know, when you say ugly things. Can you imagine what a difference that would make? When you scream and yell at kids and send them to the office and put them out in the hall and call their mothers, they get home, their mother beats them again. All they've learned is, boy, I can get everybody jumping if I say that. I think I'll try that the next time I get mad. Next time I get bored, next time I really want to see her jump up and down, I'll do that again. But if you reason with kids and tap into their feeling structure and help them see the perspective of the other child, what do we know from Piaget about perspective taking? When does that occur in children? All of you who took Lieberman, hold up your hands again. You ought to be able to answer this question. He knows everything about Piaget. But he didn't teach y'all nothing? I'll have to talk to him about that. When does Piaget, when we talk, what are the stages? Hope he doesn't ever see this. He'd be so... Hope you don't act like this about the disabilities class when you go into, you know, your methods. We know, all right, you cowards. I'm going to tell myself that you know this, but you just won't push down the button. We know that kids become operational thinkers when they're about 7 years old. Could be 6, could be 8. You know, Piaget says, you know, that it's not all of that. Chronological age is not the important thing, but they have to be operational in their thinking. You know the little example where you put up a mountain in the table and you walk around, you have the child walk around the table and he sees a house over there and he sees a store over there and he sees a car over there. I'm just making this up, but the mountain's part of the scenario. I don't remember all the details. Anyway, you have him walk around and say, that's a house, that's a car, that's a something. Then you have him stand over here and just put another child up here looking at the house, and you ask this child, what is that child saying? He says, I don't know. You say, did you see what was on that side of the mountain? Yeah, it was a house. Then what do you think he's seeing? I don't know. They can't take the perspective of the other child, you see, but they know that the house is there and they know the kid's there, but they don't make the inference that if that other child is standing there, he's looking at the house, right? So we know that about kids, so you have to help them with their thinking. You know, they can't take the perspective. Has somebody ever, but they can remember that someone hurt their feelings. and that they shouldn't be doing that to others. So we'll talk about that several times because it's such a pet peeve of mine. And not only is it a pet peeve, but it's just downright dangerous. You know, kids are carrying guns. When we don't solve these problems for kids, they try to solve them for themselves. So they just take a gun to school and shoot everybody. Right? What's the one common character? Well, I mean, it isn't really a joke. You know, it's sad. What is the one characteristic of all these kids who shoot one another? They were bullied, right? So it seems absurd. You know, we sit here and we laugh. It seems absurd. Think, oh yeah, well, right, they're going to do that. But in actuality, that's something we know that is likely to be the end result of somebody bullying somebody else. So we don't want to encourage that. And plus, even if they don't ever do anything, who wants to be participatory in a system that makes a child feel that way? Okay, back on task. There are several adaptations for students with language disabilities. Many of them are based and speech disorders too, and many of them are based on what we refer to as augmentative or alternative communication devices. The acronym for this, I don't know that you need to know it. I don't think it's, you know, particularly significant, but in short, we refer to those as ACC devices. And some of them actually aid communication in that they help children to communicate in some other way, like in using a picture board or a computer. You know, we have the electronic speaking boxes now for people who have had their larynx removed and that sort of thing. So that's a whole category of technological interventions that actually aid a person, you know, provide technological support or some other material or technological intervention for helping a child communicate. Unaided communication is a different strategy. That type really is an effort to promote the child's ability to use his own body to communicate. So we may teach children gestures or hand signals or some sort of manual signing in order to communicate to others and have their needs met. Your book gives a variety of other interventions. Most of them are really good common sense interventions, adaptations you can make in the physical environment of your classroom, like placing children near the front of the room so that you can make sure they are understanding or understood. They have easy access to help. You may need to adapt your instruction, your pace, so that you maximize the engagement and their ability to use languages to hear and respond. We may need to use some evaluative interventions so we're sure we're testing them in ways. But most of the classroom, and particularly the general ed interventions, are things that make common sense to you or are provided for them by a specialist, and you just need to incorporate them in the business of what you're doing. Learning disabilities, of course, is our next category, and this is a category that you know, will really include a preponderance of youngsters in your room who are certified as having a disability label. So, shocking as it may be, about 50% of all students diagnosed with a learning disability are diagnosed under the learning disability label. It's sort of an umbrella term that refers to a group of children who have normal or above cognitive functioning, but nevertheless have difficulties with academic tasks, which is what leads me to be much more inclined to call them low achievers rather than learning disabled. We don't know for sure if they have a disability or what the nature of their disability is, even if they have one. We've been looking for it for the 40 years I've been in special ed. You know, I taught learning disabilities back in the 60s. Hard to believe. No, hard for me to believe too. Guess what the name of my classroom was? Children with minimal brain injury. Now, there's not a scintilla of evidence anywhere. Well, I did have one little boy who had a closed head injury because he had been in an automobile accident. He had gotten hit by a car on his bicycle, and he had a closed head injury, so there was evidence. Now, in this day and age, that child would be labeled as brain injured rather than learning disabled. But there wasn't a scintilla of evidence that any other child in that class had any brain damage whatsoever. And of course, that was just really a daunting label to handle, to hang on a little kid. So we don't call children that anymore. But we haven't changed our orientation very much. We still think that there's something magical and mystical going on in these kids' brains that cause them to have below-level achievement. And I tend to think that they are low achievers, and what I know to be true is half of the children in your classroom are going to be operating below the mean because that's what the mean is. You know, by the numbers tell you that. You know, the mean is the point at which half of the kids, you know, well, the mean is actually the average, but the median is the point at which half the kids fall below and half are above. And all of our achievement tests and standardized tests and professionally constructed tests have been statistically manipulated so that the mean, the median, and the mode are all in the same place. The average, the point at which 50 fall above and 50 fall below, and the score that is the most frequently encountered are all the same because we manipulate everything statistically to make sure that they are. So I would like to encourage you to begin to think differently about these youngsters we refer to learning disabilities, because we have done some pretty daunting things to these children in the past, and we're signing up more and more and more of them as time goes by, and putting labels on them in order to obtain services for them. There are several components in our federal IDEA definition of learning disabilities. One of the things it says is that a learning disability is possibly caused by some irregular development or central nervous system functioning. It may be a lifelong condition. It may affect areas that include all of the categories of symbolic language: reading, writing, mathematics, and spoken language. We use an aptitude achievement discrepancy in order to diagnose a child as having a learning disability. And I need to explain that to you too, because it's something else. If I can progress past to a new sheet of paper. This is something I realized in past semesters I haven't explained very well. If you go back to the normalized distribution of scores, and you say that a child has a learning disability based on an aptitude achievement discrepancy, I want to show you on this normalized distribution of scores what that would mean. Say you are a fourth grade teacher, okay? And say you have a child, so you're in the fourth grade, and you have this child in there who, how old would he be? 6, 7, 8, 9 years old? Say he's 9 years old. We're right now in the September, October, November, December, January. Say February would be the 6th month of school. So the average child in your class, the one that's right, if your class is perfectly normal, and the one that is right here, what would his achievement score be in reading? What would his achievement test score be? Huh? Well, if you had a very average child and he was in the 6th month of the 4th grade, we would anticipate that he would have a 4-6 grade level equivalency. That's what that acronym means. GLE is grade level equivalency, and that's an important thing for you all to start to understand. But achievement tests are made that way. They're made so that they demonstrate that a child who's perfectly average at this time in this grade is going to have that grade level equivalency on his achievement test. So say you had this little 9-year-old kid in your room and he was functioning way down here at the 2.3 grade level equivalency. Okay? That would probably be, say he's 1.5 well, that'd be more than 1.5 standard deviations, but just for the sake of this argument, say that we'll make him the 3 it'd be better probably for him to be at the 3.3 grade level equivalency. So he's over a year behind. He's 1.5 standard deviations below the mean. See my deviations? Here's 1 standard deviation, and here's 2 standard deviations, right? Here's 3 standard deviations. That's about what it would look like. Now then, say we sent this child and had him IQ tested. And we discovered his IQ, we got a 9-year-old here. His reading is at the 3.3 grade level equivalency, and his IQ score is 115. Where would his IQ fall? Huh? It would fall, actually I know this, it would fall exactly 1 standard deviation above the mean, because that's how IQ scores are made. They have the average IQ is 100, and each standard deviation is represented by 15 points. So 1 standard deviation above and below the mean goes from 85 to 115. So if we looked at this child, how much difference is there between his IQ and his reading ability? Huh? Well, it's about 2.5 standard deviations, right? Because we've got 1 here, 1 here, and 2 here, and about 1/2 right here. And that's how we determine that a child has a learning disability. We've done this forever. I think that's changing, and we'll talk a little bit more about it in a minute. But at the present time, the way we determine that a child has a learning disability is that we give him tests and we discover that there's a 2 standard deviation or greater discrepancy between his ability level and his achievement level. In other words, we're saying he ought to be able to do better than he does, right? He's smart enough, but if he were achieving, if his achievement was commensurate with his ability, he'd probably be reading at the 4.9 grade level equivalency, wouldn't he? If this very child we described right now was reading at the 4.6 grade level, he would actually be an underachiever, right? Because we would anticipate that he would be somewhat ahead of others his own age. Does that make sense to you? If this concept does not sink in, you need to let me know, because it is fundamental to the whole concept of learning disabilities. This notion that we anticipate that a child with this cognitive ability would achieve at this level. Does it make sense? No? You'll have to tell me what doesn't make sense to you about that. What about it? I don't know. Somebody ask a question that everybody else is thinking, because I don't get it. We anticipate that a child with why don't you get it? It doesn't make sense. Do you get it? If a child is his ability level is about a standard deviation and a half, you know, if he's a little bit smarter than other kids his own age, he ought to be able to read a little bit better too, shouldn't he? So the notion with a learning disability is, if he's smarter than others his own age, why can't he read as well as they do? Well, I was as smart as other kids my own age, but I couldn't sing as well as they do. Remember? But I don't know if I'm singing disabled, you see. Even though I have average intelligence, I'm not a very good singer. I have to tell you, I'm not. I'll admit it. So, learning disabilities has an exclusionary clause. And this is the kicker right here. A learning disability is an aptitude achievement discrepancy that can't be explained by anything else that we know of, so it must be a learning disability. It isn't the result of retardation, it isn't the result of economic disadvantage, it isn't the result of a behavior disorder. He just can't read as well as he ought to be able to, and we don't know why, so we're going to call it a learning disability, right? Well, not only, yes, Brianna.
It could be like dyslexic people, right?
Well, dyslexia is a funny term. It's a funny term, dyslexia. I know what you think dyslexia means. You think it means these kids that read backwards and so on and so forth, right? That's what everybody thinks, right? Let me tell you what dyslexia means, and you can go home and look it up in the dictionary. Well, it's a Greek word, so you might have to have a Greek dictionary. But in Greek, lexia means read, and dys means can't. So dyslexia means can't read, and dysgraphia means can't write, and dysphagia means can't speak. Does that make sense to you? But we have come to create a vernacular concept of dyslexia that says it's children who can't read because they have all sorts of neurological complications, many of which result in them having reversals and seeing things differently. We've come to use that term to describe children who have some peculiar neurological functioning. Wouldn't you say that's true? But all we really know about these youngsters is that they can't read. So imagine, I'll tell you another story about me. When I was a little baby, I didn't learn to walk on time. How old is it? How old are babies when they learn to walk? About a year old. Well, I got to be 12 months old, and guess what? I was still crawling on my belly like a reptile. A very big belly it was, too. It was dragging the ground. That might be why I didn't walk. I think my mother fed me too much. But in any event, I didn't walk. I wasn't good at it. And I got to be a year and a half old, and I still couldn't walk. My mother got real concerned about it, and she actually took me to Dallas, what she called Dallas, to the doctor, who said, you know, your kid can't walk. But imagine that my mother took me to the doctor, and she said, which I'm sure she did, Doctor, I'm so worried about baby Gay. You know, she can't walk yet. She's over a year and a half old and she can't walk. And he said, well, I know she can't walk. I have to give her some tests. And so he took me in his office and he gave me a bunch of tests, and he came back and he said, oh, Miss Goodman, I know what's wrong with baby Gay. She has dyspepsia. And my mother said, oh, I'm so relieved. Dyspepsia. What does that mean? Says, well, it means she can't walk. And Mama said, yeah, I know it. That's why I brought her here. Why can't she walk? He says, I just explained it to you. She has dyspepsia. She said, I know, but how do you know? He said, well, I gave her all these tests. What did they say? They said she had dyspepsia. Now, what does that mean again? Well, it means she can't walk. Your time is up. Next customer. Next patient. That's a lot about where we are in learning disabilities. If a person has a learning disability, well, take me for example. I can't walk and chew gum, but I can walk. Where did my dyspepsia go? I'm not real good at walking. Sometimes my friend Sherry has to pick me up and get me back on the curb. I'm never good at tennis. You know, all that footwork was just beyond me. I'm probably not a very good walker. And maybe there's a reason why. Maybe something happened to me, you know, coming out of the chute. I don't know why I'm not a good walker. But the truth is I can get from point A to point B, right? So I passed the good enough test where walking is concerned. I'm probably never going to challenge that Cypriot that was in the tennis. Who watched the tennis tournament this weekend? What's his name? What do y'all do? I know I didn't study. I know you don't read your special ed book. But in any event, I'm probably never going to be any threat to Martina Navratilova, or whatever her name was, but I can get around pretty good. So when we have a child with a learning disability, a reading disability more appropriately, and we teach him to read, does he still have a reading disability? Where did the disability go? This is the harm I think we do in labeling these children in this way. I had a client one time. This man was a public racehorse trainer, made bukus of money training horses. He didn't know too much about going to school. And he had 6 kids, and all of them did fine, except one. And this one's name happened to be Will, so we'll just call him Will. Anyway, Will started to school, just like everybody else, when he was 5 years old, had a lot of difficulty learning to read, and was sent to a diagnostician and got a learning disability label and went to Sylvan or wherever it was, and someone taught him to read, but he wasn't a real good reader anyway along the way. Well, Will finally, you know, probably because he had fairly well-to-do parents and they got him the help that he needed, he learned to read and avoided a placement in special ed. But he had this learning disability label all of his life. So the kid went to high school, graduated from high school, and the kid was ready for college, and so they brought him to me. And they said, well, we're real concerned about Will. I said, why? They said he has a learning disability. I said, how do you know? One of them diagnosticians told us so when he was in the 3rd grade. And I said, well, can he read now? Oh, yeah, he reads fine now, but he's got a reading disability and a learning disability, and we're worried about him going to college. I said, wait a minute. He doesn't have a learning disability anymore. Did he graduate from high school? Yeah. Was he in special ed? No, he wasn't. No, but he has one of them learning disabilities. We know, though, because they gave him the test. We told him when he was in the 3rd grade. I said, well, if he's going to school now and he's doing fine now, you don't have to worry about that. He doesn't have, yeah, but when he gets to college, it might cause him a problem. I said, everybody in college has a problem. Mostly their parents have a problem writing checks. You know, I don't know why you're worried about it. Well, this man worried himself sick. This child got a college degree and went on to graduate school, and his dad was still worried about his learning disability. Now he has a master's degree in sports medicine or something. He's making about $75,000 a year, and I guess his dad's still worried, you know, about this reading disability that was diagnosed when this child was 8 or 9 years old. We've been teaching mentally retarded youngsters to read for 40 years that I know of, because we used to do it all the time back when I was a teacher. We didn't teach them to read when they were 5 or 6, but by the time they were about 9 or 10, we did a pretty good job of teaching youngsters with mental retardation to read up to the level that they could deal with language, you know, as long as they knew the vocabulary. And of course, all children with mental retardation didn't learn to read as fast, some as fast as others. There was the same distribution of scores with this population as there is with other populations. But I would like for you to rise above this rigid label in your thinking about youngsters with learning disabilities, because it's very limiting to children, and it's quite a misnomer for us. I want to ask you this question. This is on the dyslexia thing too. Looky here. Oh yeah. This was one of my children. He used to write his name like this. I blame this and everything else that's wrong with my children on their father. I think that's fair. His father taught him to write his name in capital letters, not I. I'm a first grade teacher. I have perfect print. But sometimes he wrote his name like that. Does he have a learning disability?
No.
How would you know?
Well, he can write it correctly if he wants to.
Well, maybe not. Yes.
But, I mean, aren't there some people that are always going to be dyslexic? Because, I mean, I've had teachers that are always writing numbers backwards and they say they're dyslexic. And I have friends that have to use, like, colored sheets of paper to read and stuff.
Well, I don't think there's any one answer to your problem, to your question. I think there are as many challenges to learning as there are children. In this particular case, the operative question there is, how old is the child? Because if a child were doing that when he was 3, he would probably be advanced. If he were doing that when he was 8, he would probably be quite behind others his own age, right? In this particular case, the kid was in 4 or 5 years old, and when his handedness hadn't been established yet, whatever that age, UEC teachers ought to know that age at which kids sometimes pick up pencils. Their handedness hasn't been decided. If he picked up the pencil with his left hand, he wrote from the left side of the page, and if he picked up his pencil with the right hand, he wrote from the right side of his page, but he hadn't learned to pick up the pencil with the right hand and move to the left side of the page. And so, of course, as his development advanced, this type of reversal pattern dropped out for him. But certainly we do have teachers, and I can tell you to this good day on my computer, I'm doing these very transparencies. I spell there wrong, T-H-I-E-R. If it hadn't have been for Bill Gates, I would have had that reversal, and I've been writing there, T-H-I-E-R. You know, I've been writing that, I'm sure, since I was 6 or 7 years old, and I can't tell you for sure. Usually I automatically do it correctly. But if you asked me how to spell that, I couldn't. And today, apparently, I didn't spell it right because I looked down and the spell check popped it up right. So certainly, I think there are those among us, and I wasn't a particularly good reader either. Both of my children actually were better readers in school than I, and that could have had something to do with why I couldn't walk at the right age either. I don't know. But certainly, if visual aids help people, they ought to use them, and there are many people who believe that they do, but we don't know why those things are so effective in working with people. And to try to say it's some neurological function or it's this or that or the other, we don't know that very well. But my belief is, if an intervention works and it isn't harmful to anyone physically or psychologically, we darn sure ought to be using it. But I wish we would take a broader perspective in looking at normalcy and saying, gosh, it's okay if the bottom half of the kids don't learn to read as quickly as the top half do. That's the nature of the halves. You know, half of the kids are never going to learn to read as quickly as the other half does, and they may never be as good at it. There are some of you in here who are if we had this class on a distribution between those who were the most efficient readers and the least efficient readers, we would have a wide variety of reading ability levels. But all of you have learned to compensate for the extent. Maybe you read real fast and it's a snap for you. But maybe you're in the group who doesn't read quite as quickly and it's more effortful for you, and you have learned to compensate by spending more time doing it, or providing prompts for yourself, or doing whatever it takes to make you successful. You have provided the strategies for yourself that make you successful. And if there's something I can do as a teacher to make you more successful in learning what it is, or exhibiting that you know what it is I want you to learn, I want to do that for you. Because I know it's harder for some people than it is for others. And that we're all on a continuum. So I want you to think about those things when you're working with children who are below grade level achievers in reading and math. Because if you're in a regular classroom, a whole bunch of the kids are going to be below grade level in reading and math. There's no question about it. Why? We don't know why. Yes.
I was just wondering what age your son was when he was writing his name like that.
Oh, he was about 4 or 5. I think he was in preschool.
Okay.
And it didn't bother me at all, because I knew I used to be a kindergarten teacher, and I know it's developmentally normal for young children. But I want you to think about, especially those of you who are early childhood teachers, I want you to think about developmental delays rather than disability labels, because everything we know about developmental psychology tells us that child development is on a spectrum. Some of them are going to develop more quickly, and some of them are going to develop less quickly. But it's an absolute crime to make a child disabled because he is exhibiting at 5 what the average child has. You know, his profile at 5 looks like the average child's does at 4, or vice versa. If he is exhibiting at 5 what the average child does at 6, when by the time he's had a little more time to mature, he might catch up. My problem is that we have a window for teaching children to read, and we say, you've got to, boom, you've got to do it when you're 5 years old or you miss your chance. You know, and we are requiring children to exhibit skills at 5 now that I know many children could not exhibit at 6. Years ago, when I taught first grade, there was no such thing as kindergarten in Texas. We did not have public kindergarten. Now, I know that most of you went to school and you had kindergarten, because it was started in about the, 60s, about the mid-60s, so you had that when it was already institutional by the time you went to school. But I taught first grade. We had readiness, what we generally consider as kindergarten activities, we did during the first 6 weeks of first grade. And even at that, not all children learned to read on time. So, and kindergarten was originally thought to be compensatory. It was a program that we implemented to give particularly children from homes where books and crayons and pencil and paper were not an ordinary part, more practice and experience doing these things. But now we have shifted a great deal of the first grade curriculum down into kindergarten. And of course, commensurate with that has been a big rise in the incidence of youngsters labeled with a learning disability. Does that make sense to you? So I want you to think about providing a broader interpretation on what you consider individual differences rather than being so quick to respond with a disability label. Because if a child learns to read adequately, it doesn't really matter if they learn it when they're 5 or they learn it when they're 10, as long as they learn to read. The problem that we have is not children learning to read so late in life. It's illiteracy. The problem is that they had that window and they missed it and we never go back and teach them again. Or they have developed such a negative affect about reading that when we go back to teach them, they immediately shut down and have a mental block against it and never learn to read. And that's my concern, is that our efforts to teach children more and more earlier and earlier has in fact resulted in our teaching less to fewer. Many kids do catch it and they become independent readers much sooner, and that's certainly okay. But we ought to be initiating reading instruction based on developmental readiness for reading rather than chronological age, which is our single most important factor for when we start reading instruction. When they turn 5, they go to school, and when they go to school, they learn to read. And it isn't working very well. Many children, and particularly little boys, have a great deal of difficulty learning to read. So on that happy note, we'll take a break. I'll see you in a few minutes.